Problem. Welcome to everyone. What we're going to do this evening is go through a brief overview of SmileTRU and the different options that are open, and maybe give you a couple of good clinical hints that you can use. And then we'll end the discussion with an open discussion of any questions that you might have. So SmileTRU is probably the leading clear aligner company in terms of being able to diagnose cases, because they're actually diagnosed back to the underlying problem as opposed to just one size fits all, and which is typical of all the rest of the aligner systems. Basically what we're doing is we're marketing facial beauty, and it's the female that's more interested than the male. So about 75 to 80% of your cases are going to be female patients, because they are the ones that are more interested in the aesthetics. So a good smile is the key to a beautiful face, and whether you're male or female, the smile is really what makes things appear aesthetic for you. Look at a good example here. This is a very attractive lady. Obviously she has a very good smile. Another very good attractive lady, and you'll notice all you see are blocked out canines. So you can understand how a person that has that type of a smile wants an aesthetic fix. And as you start doing aesthetic cosmetic orthodontics, you have to view it totally different than standard orthodontics, because when we do normal orthodontic cases, we strive to get everything perfect. Midline's ideal, balanced class 1 cuspid, everything. And you just can't do that with just aesthetic orthodontics. You have to start making some compromises. It's just important that the patient understands what compromises you're making, such as we'll look at a patient a little later in the presentation that has a TMJ dysfunction. And if you don't make that patient aware of the dysfunction and aware that there are other options other than the aesthetic option, then that can present a problem down the line. So we'll go through that in a little bit more detail. But a beautiful woman is immediately assumed to be competent and intelligent until she proves she's not. And so this affects people in their jobs, for example. You'll have a lot of female patients that feel like that their aesthetic smile is keeping them from being promoted within the workplace, where a guy just doesn't feel that way. So what we're going to do is promote basically to offering the female the aesthetic orthodontics. So most guys are in a position where if you don't protect your practice by doing some type of cosmetic orthodontics, whether it's SmileTRU, possibly CFast, some type of cosmetic orthodontics, the adult wants it done, goes down the street to somebody that is doing it, and you end up losing the entire family. So you almost have to do some type of cosmetic orthodontics to protect your practice. So let me explain the various levels of SmileTRU, because it's a little bit unique over the other aligner systems. Basically, the level 1 just deals with the 6 anterior teeth. Sometimes you can do that on just the lower arch only. Sometimes, like retreating a past orthodontic case, you can do some IPR on the lower, realign the lower incisors. Usually it is done upper and lower. And it's very unusual to be able to do just an upper, not a lower, because of the incisal interferences. The next level goes back through the second bicuspids, so it's reset 5 to 5. And as we get into the case presentation, this is what we're going to shoot for most of the time. Because if we come in at a level 2, what we can do is round out the arches, increase the smile line, which we'll talk about here in a moment, reduce the IPR. So what we're going to do is start with a level 2 and then be happily surprised if SmileTRU comes back to me and says one of the other arches can be done with a level 1. So it's positive marketing as opposed to negative marketing. So most guys just starting out stay at these first 2 levels because it really requires very little skill other than to be able to put on the attachments and do the IPR. And the laboratory does all the diagnosis for me. As I really expand my skill level, I can move into level 3s where I reset everything. And this will change the occlusion. So we'll talk a little bit about that and how it affects the temporomandibular joint. And then for you guys that are really experienced, you can pre-treat cases like with alpha appliances, develop the arches, open deep bites, reposition mandibles, and then finish with the SmileTRU, and that's the level 4. So levels 3 and 4 definitely require cephalometric analysis as part of the treatment plan. Levels 1 and 2, the Sep is optional. We can do it with or without the Sep. A lot of guys, especially in the United States, if it's the standard of care, go ahead and take the Sep on every one of them, just so they are protected from a medical legal standpoint. So let me just give you some examples of these various levels. Here's a patient that had a level 2. You can see we've rounded out the arches significantly, been able to reduce the IPR. And this is one that you sent at the end as a level 1, they would have had to come back to you. So it's got to be a level 2. So far better to positive marking. One of the many problems you bump into here is a patient will come in and say, Dr. Truitt, I just want you to close the space between my 2 front teeth. Well, you have to explain to the patient that the traumatic occlusion, it's just that caused the loss of the upper left central, is what's causing the spacing problem. And until you eliminate that by treating the lower out of the way first, you can't close the space on the upper. So to the layperson, that's fairly difficult to understand. So you have to take the time to explain to them the cause and effect. This is a good example of a patient that had been going from one practice to another, looking to improve her smile. The best deal she could get was full coverage, cuspid to cuspid on the upper, and optional endo on that upper right lateral. And what we've done here is just simply go through the level 2, round out the arches, align the teeth, and then we've been able to go ahead and veneer that one in standing lateral incisor after we put it out and corrected the torque on it correctly. So you'll notice that lateral has a greater smile or greater gum line than the adjacent teeth to start with. Then you notice it's leveled out on the relative to the rest of the teeth on the after pictures. And what we're talking about there is torque. So anytime you see a patient that has a gummy smile line or irregular gummy smiles, what they usually need is torque as opposed to intruding or extruding the tooth. So a lot of you patients will come in and tell you that you had ortho done when they were younger, and they'll say, Dr. Truitt, I must admit I didn't wear my retainers well, so you don't tell them the orthodontist made a mistake in the first place. But a lot of patients will come back in and tell you that they simply want it done, but they will not go back through braces the second time. So knowing what cases are treatable, that type of thing is going to be part of the key. And that's where SmileTRU comes in for you. We'll come back to. So do you have it now? Why choose a level 2?
We can see and hear you, and we'll carry on from now. Thank you.
Okay, doke. Distribute the IPR over more teeth, which obviously reduces the amount you have to do to an individual tooth. The IPR on anterior teeth is much more anesthetic than posterior teeth. They start to look block-shaped. So if I can reduce the IPR, that makes it much more aesthetic. Then once I get posteriorly, it's easier to get to the class 1 cuspid relationship, which helps with the stability. I can improve the vertical smile axis, that's rounding out the arch transversely. And so all of those things I can't do with a level 1. So if I tell the patient it's going to be a level 2, it's very easy to go down to the level 1. It's very tough if I tell the patient it's going to be a level 1 and then have to explain why it's a level 2. So that's quite negative marketing to do that. So it's imperative that the patient understands the presentation. You retain only about 30% of what you hear, but 70% of what you see. So if you're just talking to the patient, they're only getting about 30%. If they can visually see things, and they're getting much closer to the 70%. So what we do with all of our patients is we prepare a little PowerPoint presentation using the patient's actual photographs. And the photographs you need for this are the full face smiling, the full face, and then the profile. And then what we do is point out to the patient the various relationships that are aesthetic, like the vertical axis of thirds, which is really Da Vinci's 2/3 equals 1/3. And if a patient has an open or a closed vertical dimension, changing that will obviously affect the lower third. And when you're doing that, it's important to point out to the patient the positive things, because this patient has very excellent balance in the vertical thirds. And you see here, regardless of race, those thirds stay the same. So the volume in each third changes with the facial typing. Left toes having the greatest, dolichos the least. It's the distribution in even thirds that's critical. The next thing we do is the vertical smile axis. So you use a transorbital line, a line tangent to the medial edge of the iris with the female looking straight forward, and you drop a perpendicular to that transverse line. And when the female smiles, the corners of the mouth should come to or beyond that line, and there should be no dark corridors. So this lady has an excellent vertical smile axis. So the point there, taking her up to a level 2, is not really going to improve that at all. And you can see here, regardless of race, you have that situation. Then the next relationship we'll look at is what's called the horizontal rule of fifths. And that simply means that the interocular distance has to be slightly greater than the nasal base width. And this lady's quite well balanced there. Then the ocular distance itself should be that same fifth. And then the distance from the outer edge of the orbit to the outer edge of the face, that fifth again. So you'll notice this lady's doing two things. She's wearing dark eye makeup. That makes that look much larger. And then she has her hair pulled forward. So showing the female how to wear makeup can make a big difference, because she's deficient in that lateral fifth, and moving the hair forward makes it look more balanced. And again, you notice the same thing with this face. She has excellent width of the interocular width, matching the nasal base. And then she's masking out the other fifths with dark makeup and the hair pulled forward. So if the patient sees all these relationships on their own face, it makes a great deal of difference. The next thing we're going to look at is a lateral view. And for some reason, every female seems to think her upper incisors are protrusive, even when they're actually quite retrusive. So if you mention this to her before she tells you she thinks her teeth are protrusive, then she'll never mention it again. Basically, what I'm doing is using the Frankfurt horizontal plane. And then I use something called the brow-beer nasal vertical, which is a soft tissue nasion perpendicular to the Frankfurt. And then the nasal bone itself, which Memler calls factor 10. I can then draw the upper lip angle, measure it back to the brow-beer nasal vertical, and the upper lip angle should be equal to on the female or greater to than the nasal base. The other thing I'm looking for is at least half of the physical position of the upper lip should be forward. So if you point out to the lady that if she doesn't have this relationship, her nose is going to look large, she won't ask you to retract her upper teeth when they don't need to be retracted. Then regardless, male or female, there's a relationship of the mentalis crease aesthetically to the brow-beer nasal vertical. It's plus or minus 3 millimeters. So these basically are the things we're looking for: the upper lip angle, the upper lip position, and then the brow-beer nasal vertical plus or minus the 3 millimeters. You can see this patient's nose looks large, not because of the lip angle, but because of the lip position. Her lip angle's good, the position less than half is forward, and that makes the nose look large. Her mentalis crease is well balanced. So we're looking for those three aesthetic things in the profile view. And again, we use the patient's own photograph for that. So we'll look at some of what's considered to be some of the beauties of the world as we do this. You'll notice most of them are leptoprosopic. Some of them even have a class 3 tendency. But they all have that balance we've just discussed. She has a very large nasal base, but it doesn't show. The same with this lady. And this last lady is a typical 4 bicuspid extraction case. You can see the whole upper mid face is caved in. So something like this showing on your waiting room TV can be very, very effective in attracting new patients. Sorry about that. So the advantage of SmileTRU, it's easy for the doctor and the patient, totally invisible. Positioners are removed for eating and hygiene, and that can be a real issue if there's a periodontal situation involved. The appliance doesn't interfere with their speech. And so as you market, you have to market back into these things, because the first question the female will ask you is not how much it costs, but are people going to see it? Then she'll ask you, does it interfere with my speech? Do I have to adapt to it? And then finally, she'll come around to asking you how much it's going to cost. So marketing as to what it actually costs comes as the last step. And probably the biggest advantage over any of the rest of techniques is this constant technical support that comes back from the laboratory in terms of the assistance in diagnosing any problems you're having mechanically along the line with it. So it's a one-on-one relationship. And then for you guys that are more advanced in the orthodontic end of it, you can modify it so you can take on more difficult cases. And we'll look at a couple of those modifications here. So let's talk a little bit about what I need to get started here with my first case. We need very good models, impressions, or a digital scan. We can use any of those three. So a lot of guys are into the digital scans. You can just send the scan straight into the laboratory. You need a registration and the functional centric relation. And then if you're scanning, you scan in that functional centric. The panoramic or full mouth, preferably a panoramic, for all cases, even a level 1. So the point is there, the laboratory can't tell things like ankylosed teeth or possible bridge abutments, implants, that type of thing, without a full mouth series. So the panoramic is usually the better of the two. You need your photographs. Most people use their cell phone for this, but there are 5 intraoral. That's the upper and lower occlusal views, 3 views and occlusion. And then the 3 extraoral photographs, full face smiling, and profile. TMJ records are essential because you've got to document any pre-existing temporomandibular joint dysfunction for 2 reasons, really. You don't want the treatment to make it any worse, and you need to document it as a pre-existing condition. Then you need a patient history that's relevant, and probably the most important thing there is the chief complaint of the patient. So it's really important you tell the laboratory exactly what the chief aesthetic concern is, because they tend to concentrate on the mechanics, getting a mechanical balance that's ideal. And sometimes the patient's not concerned about that at all. It's a particular tooth that they feel is a little protrusive or retrusive or rotated or whatever. So the more information you give the laboratory, the more information they can give back to you in terms of a treatment plan. So the cephalometric X-ray, or the tracing of it, is optional on level 1s and 2s. It's mandatory levels 3s and 4s. So what you receive back from the laboratory is the treatment plan, according to whatever level you've selected. And if you selected a level that we can't do, then we'll come back to you and tell you that is part of that. The laboratory will send you the setup at the various levels you've requested. The technical support is constant. There's no additional charge for that. The model analysis for the cast analysis is an additional charge if you're going to develop the arches. And then the cephalometric X-ray is an additional charge as well. So numbers 3 and 4 you can use on any one of the levels. You have to have the Schwarzkopf and the member computer for level 3 and 4. So this is just an example of what you would receive back. So you can show the patient exactly what to expect within general terms, where attachments are going to be, that type of thing. Be sure it meets their aesthetic need, and then we'll go from there with it. And any changes you want to make, we can make for you at this end, and then come back to you again with a second presentation. So if you're going to use impression material, probably alginate is the very best. That way you can use any type tray with it, and just be sure that the teeth are all recorded all the way through the second molars, and be sure none of the teeth penetrate the alginate and contact the tray. So if SmileTRU comes back to you and says, we've got our distortion in the impression, believe them, go ahead and make a new impression and get a good one from the very beginning. So alginate is the very best material for this, as opposed to polycarbonates and that type of thing. So if it requires a cast analysis, what I need to be aware of is, irregardless of what I'm going to do in terms of IPR, the lateral incisor should be 2 millimeters less than the central. So the most common central size is 9 millimeters. That means I should see a 7 millimeter lateral. So if I get a case that has like a 6 millimeter lateral, I'm going to have to bond that lateral to bring it back up to size to balance its relationship. And then sometimes I see macrodontia where there's less than the 2 millimeter differential, which simply means there's going to be a lot of IPR. It could even be an extraction case. And then obviously you need study models for your presentation to the patient. I personally still like to use the actual stone models as opposed to the digital, because you can just see a little bit more and point out more things to them. But they will make you the digital models as well, so you can go either way with it. So there's actually two ways to evaluate these arches. One is to look at measure the amount of bone you have, measure the size of the teeth, realize you increase the arch size slightly with the aligners, and then you make the teeth match whatever skeletal base you have. The other way is the reverse of that. You analyze the bone, and then if the bone's too small for the teeth, that's where things like ALFs or insaginals come in to change the skeletal size. So there is going to be a limit at how much you can IPR a case before you need to develop the arches. So they're just simple measurements made anteriorly and posteriorly, and then we can measure the position of the upper incisors in the arch. So as long as I'm doing a level 1 or 2, that tells them the dental division without a cephalometric tracing. And then I've got to compare skeletal versus dental midlines, which is the mid-palatal suture. You notice this patient on the top right of the screen, when you get into the premaxilla, the suture deviates significantly to the patient's right side, and that carries the labial frenum with it. So I can have skeletal or dental midline shifts, and we'll pick that out for you because this patient needs to be pre-treated to align the skeletal before you can align the dental. So the proper Roman arch is established. That's using the buccal force planes. And all this is done for you with a setup that we send to you. So they just simply take the width of the 4 incisors, make a projection as to how wide the maxilla and mandible should be at these points. And then that gives them perspective over whether it's within range of treating with SmileTRU and the aligners, or whether you need to pre-treat it. And they'll come back to you with a treatment suggestion if it does need to be pre-treated. So this is typically what you would get back from the laboratory with the analysis, an appliance drawn for you if it requires an appliance. So those move into the level 4s. One of the more important things to understand is when you have a class 1 cuspid relationship, the volume on the upper has to be balanced against the volume on the lower. And classically, what happens with microdontic laterals, they'll over-retract the upper incisors, which forces the mandibular condyles backward, and that causes the TMJ dysfunction. So this particular patient has very slightly microdontic upper laterals, but it's not affecting the dental midline. So what we're doing with it is IPRing the lower equal to the microdontia on the upper. So there's actually two ways of balancing this volume. I can add volume to the deficient member, or in this case, reduce volume in the opposite member. So the panoramic radiograph is taken for every level. So we can look for things on the pan like root resorption. You can see this patient has a lot of root resorption from the previous ortho. And that needs to be pointed out to them from the very outset, because this is not a good case to be moving teeth, because you're going to lose the lower right central and so forth. So all that needs to be documented as a pre-existing condition. So teeth that have had endodontics, you need to come back with periapical radiographs and look for lamina dura around the apical third, because they can be ankylosed. Same is true of fixed or removable bridge abutments. So if those are included in your setup, you need to be sure you give the laboratory periapical film so they can check for the ankyloses. Obviously, implants have to be treated around. Sometimes you can change the crown on them. Sometimes you simply have to replace the implant. And then if there's active period going on, that has to be under control first. So the last thing you want to do is start treating teeth orthodontically into an active periodontal situation. And then the root resorption, which we've just seen, which is critical to document as a pre-existing condition. So most people use their iPhones for the photographs now. The resolution is just excellent. And you can do it without mirrors if you have the proper retractors. On a female, I'll sometimes take this fourth view, which is a 3/4 profile smiling. That lets me give her a little bit more idea of her nose-lip relationship if she's asking me to retract her incisors. Then those are the photographs we use in the presentation. These are my intraoral photographs. 2 occlusal views, 3 views in occlusion. You can see they're taken without mirrors. So if you have the correct retractors, those work quite well. And then we take something called an ascetic view if there's attrition on the incisors, because you'll notice what will happen here is when you do the setup and you align the teeth, then you have all these irregularities in the incisal edges. So it's difficult to see that without having the patient separate their teeth slightly and take this anterior ascetic view. So that view is optional depending upon the patient having attrition of the upper incisors or the lower incisors. And these are the cheek retractors you can use, so you don't have to use mirrors. Any of this you can get from O. Symptometric X-ray. And then we'll do the tracing for you, but probably more important is we'll read it for you with a little narrative that comes back to you, and that documents everything well, plus it's really necessary for a level 3 and 4 case. And then the form the lab will give you, and probably the most important thing on the form besides selecting what level, is the patient's chief complaint, or the very most important thing the patient's concerned about aesthetically. This is an example of what you get back with the case presentation, where the attachments are and all of that sort of thing. It gives the patient a pretty good idea of what to expect at the end of the treatment. So it's not an ideal, you won't end up precisely like that. It would be very, very, very close. And then once you and the patient approve the treatment plan, then it goes into production and they produce the aligners. So let's talk a little bit about interproximal reduction, something called IPR. You get a chart back with each case, assuming that IPR is needed. And the chart will tell you exactly where to IPR, the amount of IPR, and where in the sequence to IPR. Sometimes on the more simplistic cases, the IPR will all be done at the very beginning. Sometimes it has to be sequenced into the aligner therapy. Probably the easiest way to do the IPR is with crick strips, and to make these anteriorly and posteriorly. And you get a little chart that tells you how to progress through to get the appropriate amount of IPR. Leaf gauges, so you can be sure you've actually IPR'd the exact amount. And I think O gives you a set of leaf gauges with your first case, so you have that to give you a pretty basic understanding of where you're going with the IPR. Then as you get a little more experience, there are machines that will IPR for you, and you can just see what works best in your hands. Anteriorly, IPR can be done manually pretty easily. It's when you get posteriorly that the machines really help you. So the obvious question is, how much space can I gain with IPR? It depends on where I'm IPRing. Anteriorly, you don't want ever to exceed 1 millimeter. Posteriorly, you can move it on up higher than that, sometimes even into restorations. And then as I move into the level 2s and onward, I can actually gain space by rounding out the arches. So the idea there is to try to get as much of the IPR posteriorly as possible. And then obviously that moves you into the level 2 out of the level 1. Some teeth have to be moved before they can be IPR'd. So it's what's called staging. So for example, this lateral is going to need IPR, but we'll have to get the other teeth out of the way first. Then we'll do the IPR, and then the tooth will move. So that'll all come back to you. One of the bigger mistakes a lot of guys make is they over IPR, and then they come back in and have to close space when it's all over with. So a pretty good rule to follow is once the IPR goes over 0.3 mil, like it comes back 0.4, go 0.3 with it and see if the tooth moves well. Check it with dental floss in 4 weeks and just see if it's moving, because once you go over 0.3, it's awfully easy to over IPR and you actually get 0.4, sometimes 0.5. Look at the various attachments that go on. So these are just composite attachments that are bonded to the teeth, just like you would a composite restoration. So they come in an attachment matrix, and they'll be marked in color on the outer surface of the matrix so you don't miss one when you're placing them. And then the actual trays. And one of the advantages of SmileTRU is you get the actual model back from the laboratory. So if a positioner breaks or you lose one, then you can remake it right there in your office. So the material's 0.7 mil, and it's just simply sucked down with your normal suck down machines. So depending on where the attachments are, the matrix may come to you in 3 pieces or 2 pieces. And the different attachments do different things. Horizontal attachment placed vertically, or rectangular attachment placed vertically, gives you a change in angulation. Pressed horizontally changes the torque. You can use it for additional retention. Buttons are usually used for rotations, and generally there'll be a button on both the labial and the lingual or palatal surface of a tooth to give you a better fulcrum correcting the rotations. So placement is basically just composite edge restoration. So if it doesn't involve one of the anterior quadrant, then you just have it sectioned in 2 pieces. If it involves all 3 anterior and the 2 posterior, it'll come back to you in 3 pieces. Key is to put them on one at a time. I like to use the clear composite. That way you don't have to shade it and it doesn't shadow. If you shade the composite to match the tooth, then you can actually see the attachment on the tooth when the patient turns their head in different directions through the shadows. So the clear material just simply won't shadow. So they're basically 3 steps. Fill a little matrix from the base up, then compress it with a spatula, then wipe it clean so there's no excess when you seat it. So those are the 3 basic steps. Fill it from the base, you don't get air. Compress it so it's into all corners of the matrix. And then clean the excess before you place it. So there shouldn't be any flash, any excess to clean off if you've done those 3 steps correctly. Pretty good point there. If there is excess, then you probably missed the matrix. I'd cut the attachments off and replace them a second time. And then save your attachment matrix. Don't throw it away, because if you lose an attachment down the line, you can cut that particular tooth out and replace it. It's very simple. You put it right back where it originally started. And be sure to hold the matrix firmly against the teeth before you cure it. And as I mentioned, there should be no excess composite when you remove the matrix. So this is the point to be very, very careful. If you're sloppy with it, you're going to get a bad result. If you're accurate with it, success is right from the very beginning. So the whole key is spend a little time at the very first to do it correctly. Anything on the lower arch is easier to do as long as you're not using a rubber dam with these cheek retractors. So they retract the cheek and the tongue simultaneously. So we use those when we're placing the attachments on the lower. The upper you just isolate with cotton rolls. So you can see we've gone through the acid etch process, placing the matrix, top right picture, curing the matrix, holding it firmly, and then pull the matrix off. And the easiest instrument to use there is the hook that's on a shear band seater. But just save the matrix, don't throw it away. Because if you save the matrix and you lose an attachment, all I have to do down the line is cut that particular tooth out of the matrix. You can see top left picture, we've cleaned the remaining composite off the tooth, re-acid etched, using that segment cut out of the original matrix to replace it. And you'll notice in the 4th picture that the other 2 attachments are on with shaded material. This one we replaced with clear material, so you can see the difference in the shadowing there. So that gives you some perspective of why you want to use the clear as opposed to trying to use the shaded composite. Then obviously, if you're going to put an attachment on a crown, you're going to have to go through another step with the silane couplers. So Monobind Plus is probably the best one out there. There are a number of them if you have something you prefer over than that, but you have to do a separate step with it for the silane couplers. And then what will also happen, if you give the laboratory the panoramic where they can really see what's going on, they'll try not to put attachments on teeth that have crowns. And that's obviously the best bet if you can avoid it. Then it's very important for the patient to understand that they place and remove the positioners in a strict order. They go from the posterior to the anterior to the posterior. So that's the path of insertion. So most patients do the reverse. They'll put the anterior on first and try to seat the 2 posteriors. That's when you start breaking attachments, breaking the matrix, all of that sort of thing. And then it comes off the same sequence, posterior, anterior, posterior. So it makes no difference which side you start first, but that's the sequence. So we'll talk about a couple of problem solution situations here. If you have just too much retention in general, then usually what that means is you need to shorten the length of the matrix, the height of the positioners, and that'll reduce the retention. So this sometimes happens if you have teeth that are very round in shape and they have a great deal of undercut. You may have to reduce the actual height. So you have to be sure that the patient can take them on and off. Just because you can place them and remove them doesn't mean the patient can. So the patients, before they change each one of these, I have to be sure all the teeth are properly seated into each individual matrix, and that's called tracking. So I can have basically 2 types of tracking problems we'll look at here. But this is the way it should look at the end of the time, each time. So see on the top picture, there's just a little bit lack of seating all the way. 2 weeks later, you can see everything's tracked into the matrix. So if I don't see all the teeth tracked into the matrix, I'm not ready to make the change. So typically, you'll put the first one on, give the patient the one to change in 2 weeks. They change it, come back in 4 weeks, and that's the sequence you normally go through. But sometimes you have to slow the sequence down, and I just simply tell the patients that some patients' teeth move faster than others. The mistake is to do like this one is being handled. It's not tracking, and they're continuing to advance it. And as you do that, you just totally lose control, and you have to go back in and do what's called an in-treatment adjustment. So a pretty good rule to follow is this. As long as each one of these come in letter sequences, so you have like an A 1 through 6, B 1 through 6, as long as you're just simply one number out of sequence and you have a tracking problem, going back for another 2 weeks will usually solve the tracking problem. If you get more than one number out of sequence, like you're at A3, A4 didn't fit, but now you're in A5, very frequently you have to go back in and make a new impression. You can't just back up to the A4. So try to watch that very, very carefully, because as long as you're one number out of the sequence, usually just going back a previous number will solve the problem. So 2 weeks is an average, but you may have to slow down for some patients. And just simply tell them some patients' teeth move faster than others. If I have individual teeth that aren't tracking, we can do something called a slingshot. So what we've done here is we've simply cut a window in the labial surface of the lateral incisor, and you can actually bond a clear button on or put an attachment on the tooth. And you come around to the palatal with a separating disc and cut 2 notches. Then the elastic is a 1/8, 4.5 ounce, and you put it in the positioner first. Patient seats the positioner, then pulls the elastic up over and drops it around the attachment you put on the labial surface. So that's the best way to do it if the tooth moving doesn't have a previous attachment on the labial. Now sometimes I want to do this same slingshot and there's an attachment already on the tooth on the labial. So in that situation, you just reverse it. You bond a button to the palatal of the tooth, then you'll cut out the window so they can get to it with the elastic. And then the patient puts the elastic on, puts the positioner in, and then pulls it over the top and drops it around the attachment that's on the labial. So there's 2 ways of doing the slingshot, depending on whether that particular tooth has a previous attachment on it. And then this is a presentation in the States that are sent back, but you guys have a little different one in England. But it's the same thing. You get the positioners, you get the attachment matrix, you get the attachment tool, the removing tool, and then you get a retainer box and the instructions for each patient. So the protocol for doing this is when you get the positioners back, you check the fit before you ever do any attachments. That's very important, because if you don't fit properly, then you know it was an impression problem. If you wait to check till you put the attachments on, it doesn't fit, you don't know whether it's an attachment problem or an impression problem. Then you clean the particular teeth that have attachments and acid etch them. So you're quite used to doing that with your standard bonding. Got a choice if you're using the shade or the clear. I much prefer the clear composite. And you attach it with light curate. Just be sure you hold it firmly. Go through the sequence I explained to you. Remove the attachment, and there should be very little to clean. If there's very much to clean, I take the attachment off and replace it. Then you check your positioner again. And now if it doesn't fit in a particular quadrant, you know you missed the attachments in that particular quadrant. So by following that protocol, it's very easy to tell when you have a problem, whether it's an attachment problem or whether it's an impression problem. Then, assuming everything is fitting properly, you check your IPR chart for IPR. And you also need to check for the previous 2 weeks, because obviously if IPR is going to be required for the next positioner, the patient has to come in to get the IPR. They can't replace it themselves. And then I give the patient the next set, and you just go through the sequence. So you're seeing the patient typically every 4 weeks, with them making the change every 2 weeks. So the patient instructions are, they come out for eating and hygiene. The positioners can be warm when they're drinking water, but that's the only thing. Patient changes for the next one on a 2-week sequence, unless you instruct them differently. If either positioner doesn't fit, they go back to the previous one and come in immediately. And usually if there's just one number out of sequence, all you have to do is wear that particular number for an additional 2 weeks. And you're right back on the sequence again. One breaks, you've got the models to immediately put it back in so you can replace it without having to go back through the laboratory. And then we give the patient no minimum time frame, because if you do that, they start with that and they start dropping off. So it's full-time wearing, except for eating and hygiene. And the only thing they do with the positioners in is drink water. So what do I do at each appointment? First, I check the fit of the current positioner, because if it's not fitting, I'm not ready to make the change. I have to go back to the previous positioner or leave that one in for another 2 weeks. I check the patient's teeth off the model, and this is a real benefit of having the model itself. It's difficult to look at a digital image and see if the teeth are actually matching the image at that point. It's very easy to look at a model, look at the patient's teeth, and see if the two match perfectly. Because if the two don't match perfectly each time, then it's not tracking. Check the IPR chart for the current IPR and future IPR for the following 2 weeks. Place a new positioner, be sure it's fitting properly. Then very important, take it out and let the patient place and remove it to be sure they can handle it. So don't just assume they can do it. Be sure you physically see them do it. And a lot of this you can delegate to your auxiliary. It's important to keep it clean. So one option there is using the little ultrasonic cleaners with denture cleaner, and they'll just stay crystal clear. Tell them not to brush it with toothpaste. That makes it, kind of a foggy look to it. And be sure they don't boil it. A lot of patients think that they have to keep them sterilized, and that's not the way to do it. It'll distort the position. So what we'll do here is I'll show you a case, and I'll act as if you are the patient, and I'll show you basically how I go through the case presentation here. What we've got is female again, fairly young, 28 years of age. So the point there is patients aren't good candidates for any aligner system until the second molars have fully erupted. So if you've got a patient prior to that and you intend to use the aligners, you're just going to have to delay treatment until the second molars have fully erupted in all quadrants. This gal has a high profile job, and she feels like her aesthetics with her smile is keeping being promoted, and that's understandable. She's always wanted straight teeth, and that's the other thing they'll tell you is, when I was young, I wanted my braces, but my parents couldn't afford it. Now I've got a good job and I want straight teeth. I just don't want to see it under any condition. Don't want anybody to know it's being done. I've got to be able to speak and do my job. And for a lot of patients, brackets are just simply off the table for those reasons. So there are basic photographs we've made. And we've gone through the PowerPoint presentation with her. Okay, what we're explaining to her here is that if she looks at her upper midline, the upper midline matches the upper skeletal midline. So upper dental matches upper skeletal. If she looks at her lower one, lower dental matches lower skeletal. The discrepancy is her lower skeletal to the upper skeletal. So if you'll notice what happens there is the mandible rotates around, the side on her left moves forward and around, appearing class 1, and the side on the right moves further back, appearing class 2. So it's important that she understands she's got a right TMJ problem. And when I explain it to her, give her the options of fixing it, she comes back to me and says, well, it's not really bothering me right now. Can I fix it later? Yes, as long as you know it's there and I didn't cause it. So she has to sign a revised consent form. And then I have to explain to her that while I can move the teeth around to align the midline, what I can't do is move her mandible around or compensate by trying to move the teeth around to the shifted mandible. So the last thing I want to do is refine her occlusion to this deviated position and damage her right temporomandibular joint further. And all that needs to be well covered and well documented in your case presentation. And then the patient has the option, assuming there's an option on the table. So we're going through her positioner sequence here. She's a level 1. And usually they stay in the A series. So you see we're able to mask the midline shift a little, but we can't really change it that much or refine the occlusion to the deviated mandible. On the other hand, that's exactly what she wanted to see, an aesthetic change anteriorly. So we've given her what she needed, what she really wanted. We haven't really taken care of the joint problem, but she understands it's there. And then in the future, if she wants it fixed, we can always come back with something like an RN sagittal, develop her maxilla, and re-rotate the mandible. It's just that's very difficult to do with the aligners. So you can see her mandible is actually shifted to her right side. And sometimes when you point that out to the patient and they see it aesthetically, they'll go through the rest of the treatment, not because of the joint, but because it'll take the mandibular shift out aesthetically for them. Point is, though, be sure that you get good advice, consent on all the problems. Let's talk a little bit about retention. As long as I'm doing a level 1 or a level 2, I can use the final aligners as the retainers. I just simply wear them as the retainer, 6-month active, 6-month passively sequencing out. If I do a level 3 or 4 or the occlusion changes, which I'll show you an example in a moment, then I have to have functional retainers, and there are a number of different functional retainers. A functional retainer simply means there's nothing to interfere with the function between the two arches, like Adam's clasp or something like that. So these are the most popular ones. They're clear, so they're very aesthetic. And this lets the occlusion function to the new position in terms of our condyle problem. It may solve the TMJ situation. So these are not optional. You have to go to a functional retainer like this if the occlusion changes, or if you do a level 3 or 4, because you're always changing the occlusion. Then I like to back them up with bonded lingual arches, and but this can be done underneath your functional retainer, or it can be done underneath the final positioner. And then if it's an older patient that has periodontal problems anteriorly, you can use a much heavier wire, and then you actually make it into a W where the patient can clean it proximally. So you're doing two things there. You're using it as the retainer, but you're also using it as a periodontal splint. So it's fairly common to see that in the older patients as well. So removing the attachments, you start with a posterior band remover, take the bulk of the attachment off, and you come back in with either a finishing stone or a finishing burr and remove the remainder of the composite. So I don't take the attachments off for the first 90 days when I start the retention. Then I take the attachments off after 90 days, continue active retention for another 90 days, and then drop off to nighttime wearing. So full-time wearing is called active. So the first 3 months are active with the attachments. Then I remove the attachments, another 3 months of active. Then I drop off at nighttime wearing only. That's called passive. And then I sequence out 1 night per month. And what will happen with these patients is maybe I'm like twice a week at night. When they drop back to once a week, it feels tight when they put it in. And so they'll feel a change before you can actually see it. So what I tell the patient is when they're coming out of these at night, when they hit that stage where it feels tight, they have to continue to wear it indefinitely, or they are going to get some change. Some patients will just continue indefinitely. Some people don't mind a mild change occurring. Then if I'm going to go into the functional retainers, I need to understand that's an additional fee. So a couple of things I really need to know, even as if I'm just starting out here, is that I can affect the temporomandibular joint function, even with a level 1. I can have something called a division 2, where the upper incisors are retroclined, and I get rid of the division 2 and the condyle repositions. So a good way to visualize this is a patient with a division 2. When they bite their teeth together, you can see the closed position, how the condyles push backwards. But when they drop into rest position, coming out of the entrapment, condyles moving forward. And see, that's a significant difference between their teeth together and their teeth separated. So if I take that interference out with my SmileTRU treatment, what I see happen is I end up with a posterior open bite. So anytime you finish your case, even at a level 1, and you end up with a posterior open bite, what you're usually seeing is the condyles have decompressed, which is good. But then that means they have a whole new occlusion that you'll have to allow function in with the functioning retainers. So if the patient is bruxing, they can also do the same thing. They can intrude teeth at bruxing in the positioners, using it as a change from decompressing the temporomandibular joints. So at any level, if you finish the case, you have a posterior open bite, there's no option. You've got to go to a functional retainer. and a lot of options with the functional retainers. These are just the clear bow ones. Aesthetic recontouring is done after you finish the case. So this is a situation we talked about where the incisal edges are worn. So we'll recontour the incisal edges, sometimes even do some composite bonding. And then one of the ways you can look at a patient's teeth and generally tell whether they're female or male is the depth of the embrasures. The male patient has the same 20% all the way through the cuspid, where on the female, it'll start at 20 between the centrals, and it goes up 10% more between central and lateral, goes up 10% more between lateral and cuspid 10% more cuspid to bicuspid. So recontouring the teeth can make them look more feminine. And again, that's what most of the women are interested in. There's an instrument you can get called a crimping plier for aligners. And what this does is let you put little dimples in it to increase rotations. So for example, we're seeing a patient here that the lower left central is not tracking well. So what we've done is come to the labial at the distal of the central and put an indentation, come around to the lingual at the mesial of the central and place an indentation. And now when you seat it, those two indentations put extra pressure, correcting the rotation. So that's a plier you can get through O as well. It's called an aligner crimping plier. So just to look at the basics here, cases that are good to treat are just generalized anterior crowding, where I can round everything out. Anterior spacing are usually easy if you treat both arches. And then I can pre-treat for reconstruction, typically here with a laminate veneer. Cases that are not good to treat are patients that have extremely underdeveloped arches. It's way beyond the range of the positioners developing. That's a pre-treatment with something like an ALF. Patients that have extreme anterior open bites because they have an anterior tongue thrust as well as severe TMJ when they have that. So part of the open bite I'm seeing is the condyles off the disc. Patients that have large negative or positive overjets you cannot correct with just aligners. On the other hand, a lot of people that are class 2 or class 3 don't care about the overjet. They just want straight teeth in the class 2 or class 3. And that you can do, just align the anterior teeth and leave the overjet. And then anytime I have arch length loss, posterior teeth incorrectly forward, and it's excessive where I can't compensate for it with the IPR, then that's going to be an extraction case, and aligners are just not really that good for extraction cases. Now, if you pre-treat the extraction case and then come back with aligners, that's another option. And then finally, patients who have any type of severe TMJ dysfunction need to have the TMJ problem addressed first. So I'd like to give you an invitation to join and become part of this, become part of your practice. Anything that comes into Texas was seen by my wife, who's a specialist orthodontist. So you've got the backup of a specialist orthodontist, which that can help you quite a bit in difficult situations. And then cosmetic orthodontics is going to change your practice. There's no question about that. You just want to do it and understand where you're going with it. One of the mistakes a lot of the companies make is they just give it to the doctor and say, don't worry about it, just put it on. And it's a little bit more complex than that. And that's one place that we really back you up with it, is the diagnostic end of it. We won't let you do something that's going to be dangerous to the patient and we know it's not going to work for them. So it's a pleasure being able to talk to you. I might mention to you, it's a little late in the game here. We have our Congress coming up this year in October. It's a casino just outside of Gainesville here. It's an Indian reservation. So we have a great program this year with actually a doctor from Toronto who specializes in Truitt's disease. And then Stefan Kluge is out of the Channel Islands from Guernsey. And then we have a Japanese guy from Tokyo that specializes in SmileTRU. So it's going to be a very varied program, very, very good program. There's a golf tournament on the day before the Bimmer Cup. So if you'd like to get back in touch with us directly in Texas, that's my email, skip@cfo.com. And you can get on the website, www.cfo.com and SmileTRU.com, either one. And you can get back into the UK through either website. And this is your contact information at the laboratory. So I'll just leave that up there while we do the question and answer, John, because we've kind of gone through this fairly quickly. Sorry about the delay there with the computer. So do you have any questions that I might be able to answer for you?
No problem. Thank you very much, Dr. Truitt. That's very informative. We don't have any open questions on here at the moment. While some of you guys type in your open question, I'll just say a little bit, if that's okay. Started with SmileTRU in the UK or Europe. It's very simple. We have an online accreditation system. It's a short video, more process training than anything. Please just drop me an email or ring that number. I'll send the video to you, or I'll send you the link to the video. If you want to do SmileTRU anywhere outside of the UK or Europe, then please contact the Texas team directly. If you send it to me, I'll forward it on to them, so it's not a problem. You can always do that as well. A question that came in from a client today, Skip, while we're waiting for questions on here, is what if someone's got a bridge? Okay,
that's a good question.
Bridge on their upper right too.
Yeah, what we can do is we can move the abutment and one ponic, but we can't move the ponic and two abutments at once. So the bridge has to be sectioned if it's a 3-unit bridge or higher, and the ponic can be cantilevered off one of the abutments. Usually you end up remaking the bridge or coming back in and putting an implant in sometimes instead of the ponic. But from a mechanical standpoint, we can move an abutment and a ponic, but not two abutments.
Okay, on a similar note, Amy's asking, can you move around an implant?
You can move around the implant, you can't move the implant. So typically what you do there is take the existing crown off the implant so there's no interference with the positioners. And then you do the SmileTRU and then come back and redo the crown that was on the implant.
Okay, and would you put a pontic in the positioner while you're doing that so they haven't got a big glare?
They can do, if it's an anterior, yeah, they can definitely do that. And if you're creating space for a missing anterior tooth, they can do the same thing. And give them a couple of ponics if the patient just has an attachment where it'll stay in the matrix. Then the patient just changes the ponic as he changes the matrix.
Okay, fantastic. Well, we've got no further questions here. We've had quite a few that have registered and not shown up. So what I will do is I'll just edit the video to take out our small technical fault in the middle. Me threatening to sing and dance.
Okay. Also, John, if you could get that on to the folks in Australia and in South Africa.
Absolutely. I shall put it up on our YouTube channel and share that on Facebook. And then also the people that couldn't make it today, got them an email just to say it's available to view now.
Yeah, we might also mention we're going to do another webinar on TMJ overlay, TMD treatment overlay in December. It's the 4th of December, and it'll be the same time of the day or night.
Yeah, so it's planned for the 4th of December, which is a Wednesday, 7 p.m. UK time. I will share the details via email on our Facebook page. So if you haven't liked the TRIPLO Facebook page, please do like it and follow us. We'll put all our updates on there.
And you might have some friends that aren't doing ortho or TMJ at this point that might like to see an overlay of the TMJ so they understand what's going on.
Yeah. Andrew's asking about the procedure for collection from the office and return to the lab. In the UK, we have free post bags, which you can send your work in to us. We currently have a 10-day turnaround time on your digital setup, followed by a 5-day turnaround on the actual aligners once you've approved the setup. But we are working very hard on bringing that treatment time down with a goal of getting the treatment set up to you within 5 days. That's what we're looking to do. Payments, again, it'll all be done through our finance. Sorry, not finance, don't want to mislead you. The finance department will be in contact with that. So the cases are paid for up front. So if you're doing, say, a level 2 case that's 2-stage, when we send you the first part of that case, we will expect the full case payment up front. With regards to the setups, it's a £50 fee for the setup if the case doesn't go ahead within 6 weeks. If the case does go ahead, then we don't charge that £50 setup fee. So we don't charge it for 6 weeks. But this will all be covered in detail on our online tutorial. So please email me, John at TRIPLO Dental Labs, if you would like to get your free accreditation for SmileTRU in the UK. I will send you the link. We'll send you out a starter box, a certificate, a demo positioner. You'll also get a 25% first case discount to help you get started, preferably you'll do your first case on a nurse, a practice manager, or someone within the practice that's a friendly face to you. And that can be a really good marketing tool as well when you're talking to a patient about how discreet they are, and you get your nurse to smile who's been wearing it all the time and the patient didn't notice. That's very useful. Okay.
Excellent. Thanks so much for the opportunity, John.
Oh, one more question just popped up. If you do too much IPR, is it difficult to reduce the extra space? How much would it extend the treatment if you did have to close the excess space you accidentally created?
Well, obviously depends on how much excess IPR you did. I would say on average, it can usually be closed in 2, at the most 3 positioners.
Okay. Eugenie is asking about how many months did the case take that was shown. I think the level 2 case, I believe from memory, was about 4 to 5 months.
As long as they're level 1s, they're going to be within 90 days. The lady I showed you was in the 90-day framework.
Okay, so level 1, as we say, typically, you know, around 6 aligners, 3-month mark. Level 2, typically up.
Usually about level 2s are usually about 6 months, and then level 3s and 4s can be anything.
I think the one you showed early on, the level 2 case with the veneer, I believe. That was 4 months.
That was 4 or 5 months. I think it was 5.
4 or 5 months, something like that. Okay.
But generally, level 2, I would tell the patient it's going to be 6 months, and then if you come in under that, that's fine. Absolutely.
Well, thank you very much, everyone, for attending. Hope to see you on the 4th for the TMJ seminar. And thank you, Dr. Truitt. We'll see you.
My pleasure. Take care.
Bye.